It's not happening. Maybe it's not happening. She go. She got good, mom. Drop am first. Change room that day. Obe japa ni mi bana. Bana ti iyo ori e. Obe gbe japa. Fuck off. Fuck off. The videos that come over. Your advice for the man that whooped your ass in the last election. Who? No, you lost to. No. White House is putting a halt. I couldn't believe my dog.
All right, it is almost time to get started. How are we all doing? Being stuck with me for 3 hours of lecture today. My brain is a little bit fried, but we'll get through this. All right, so 2:00 on the dot. Couple of housekeeping things before we get started here. The first checkpoint quiz will be available today after class. All right, so it is an ExamSoft. I will post the password because you still need to have a password to access it, even though it's unsecure. So I will post the password right after class. It's available for download. You have a week to take it. So it will be due next Monday night at 11:59. So 2/3, 11:59 p.m. Eastern time. Yes, Nyla.
Dr. Hall, quick question. You said having you for 3 hours today. Did you mean because of our class earlier, or is this going to be a longer class?
Well, I lectured for an hour this morning, so and then I'm 2 hours right now. So the combined total of this morning and this afternoon. So again, the checkpoint is scheduled to post at the end of class. I'll post the password. You'll be able to take it, open book, open note, untimed, ExamSoft. All right. And then next week after the everybody has taken it, I can send an email to you all through ExamSoft where you can review the quiz, your grade, and your answers and things like that. I think I noticed something last night with the settings on ExamSoft as it relates to like feedback for the quiz. So if something seems weird about when you get the feedback, let me know. I think I tried to fix it all. I didn't realize that there were some hidden places for feedback in ExamSoft, but I think it's all fixed. But if something seems weird, just ask me about the feedback when you get it. The next thing is our first group has posted their critical discussion in healthcare policy and practice as it relates to women's health and paid paternal leave, paid maternal leave. So make sure you take a look at that. It looks like they did a lot of work on it. It's very organized, well referenced. So make sure that everybody takes a look at it, but especially the group that is assigned to engage with it. Make sure you write a reflection on what you've read, and then make sure that we're having that back and forth conversation for the next week, because that is all due also on 2/3. All right. I haven't read it. I've kind of grazed over it, but it looks very thorough and it looks very good. So it is a good example for what people should be doing going forward. So thank you to the first group for doing that without an example. I really appreciate the effort that you put into this based on what I've skimmed through. The last thing is that PSA groups will be posted. I have the groups, I just need to assign topics. I will get that done after class today. It's been a lot kind of juggling, and I have had to prioritize PT, just like you probably prioritize PT over this class. I prioritize PT over this class as well. So now that I'm finally getting caught up in my PT, I will post the groups and assign the topics, and that'll give you about a month to get your outline for your PSA video that's due at the end of the semester. All right, I think that is it. What questions do you have for me on anything that is related to this class? Assignments, quizzes, checkpoint quizzes? All right, you can all reach out to me via email. And I try to respond as soon as possible. If I don't respond within 2 to 3 days, just send me, or 2 days, probably just send me a reminder like, hey, where you at? Because I probably missed it in my box because there's a lot of stuff coming in. All right, so we will get started on family planning.
Dr. Hall, but I have a question.
Yeah.
Sorry for interrupting. Yeah, the discussion is done, so we are gonna do some feedback on that discussion based on the information that our colleagues gave us, right?
Yes. So you're going to read and respond. And if you look at the instructions, let me see if I can pull it up real quick. For the engagement, so if you look at the engagement instructions, whoops. It talks about providing for the reflection, if you're part of the group that is part of the assigned to engagement, your reactions, personal or professional reactions to the information presented. What are some things that you learned from what was presented, and how will this information inform or impact your future role as a pharmacist? And then you need to respond to 2 other people's reflections saying like, yeah, I agree with that, or, oh, I never thought of that, or that's an interesting perspective, thanks for bringing it up, type of thing, and comparing and contrasting how your reflections are the same or different, and posing follow-up questions. It's meant to imitate a real life, if we were having a conversation, if they presented this in class and then we would talk about it. But instead of presenting in class and talking about it, we're presenting it on the discussion board and doing our conversation there. And I had a good question come in from the first group that it's not about length. Like there's no minimum or maximum. It's whatever it takes to get the job done. But please like I talk a lot and I use a lot of words when I talk, but I try to be very direct in my communication. So trying to be direct and not expanding to make it longer just to make it longer. Like, let's be very direct with our conversation, and not trying to hit a certain amount. Let's focus on the content of interacting with each other on this topic, versus, how much do I have to do to get the 100%, right? What you have to do to get 100% is have your reactions, have your compare and contrast, and pose follow-up questions and respond. All right. All right, so we're going to talk about family planning this week. The chapters that correspond to this reading are chapters 13, 14, and 15, and I've put them again in the modules for easy access for you, so you don't have to go into Access Pharmacy and get them. So if you need extra information to fill in the gaps, those chapters are there for you to reference. So looking at the objectives today, our objectives today are going to be to describe the various types of non-hormonal contraceptive methods, discuss the pros and cons of various types of hormonal contraception, understand the mechanism of action of emergency contraception and its current availability in the United States, analyze the efficacy, safety, and appropriate use of drugs for medical abortion, and then evaluate the impact of legal decisions on medication access and patient care. So first, what is contraception? We learned last week that we have the egg that grows and becomes mature, and then when the LH surges, that egg is released, and they have about 24 to 48 hours to fertilize that egg, to have it become fertilized, implant in the uterus, and become pregnant. If we don't do that, then the uterus lining disintegrates or sheds, and that's when menstruation occurs. So it is, a miracle that people are even able to get pregnant based on the stars all aligning when the egg is being released and mature, and that there's only really 24 to 48 hours. But sperm can live longer than that. But there's a lot of times when we don't want to get pregnant. And so contraception is the deliberate act of using artificial methods or techniques to prevent pregnancy as a consequence of sexual intercourse. All right, so let's take a look at the history of contraception. So this is our mature egg, saying to the sperm, stay away. So in about 3000 BC, so even before Christ, our condoms were made, and they were from linen sheaths and animal intestines. Sounds super romantic, right? Let me just put this animal intestine on to prevent you getting pregnant. I'm glad we moved past that. In 1500, the first spermicides were introduced. In 1873, the U.S. passed the Comstock Act. The Comstock Act, you're hearing a lot about that right now in the news, because they're talking about how the current administration might use that to prevent access to contraception for patients. But the Comstock Act was passed, and it prohibited the advertisements, information, and distribution of birth control. And it allowed the Postal Service to confiscate birth control sold through the mail. It's my understanding that we have not enforced the Comstock Act for many years, but now the current administration is trying to bring that back because there are states where you cannot have a medical abortion. And so states are shipping medical abortion medications across state lines. And so people are saying that in the administration that they're going to start following the Comstock Act again because it was never repealed or taken off the books. So that is something to pay attention to right now in our current political climate. If you have capacity, if you don't have capacity, I completely understand. I don't have a capacity, but I somehow keep following all this stuff. And it's making my mental health way worse. But things to pay attention to. In 1950, we had Envoy, the first pill that was marketed in the US. So it wasn't until the 1950s, that's fairly recently, that we had a pill available. In 1965, the Supreme Court allowed married couples to use birth control, and IUDs were introduced. So before that, there was no right to be able to use birth control. In 1972, the Supreme Court legalized birth control for all citizens, so not just married people, but single people as well. So think about it, like if you're a single person right now, it wasn't, 1972 was when you got the right to be able to choose to use birth control. If you're married, 1965 is the year you got the right to choose to use birth control. That's really not that far along. So what, 72 was 50 years ago? Not that long ago. In 1980s and 1990s, we developed implants, the vaginal ring, injectables to the market. So this, people, it's hard to remember to take a pill every day. And so doing things like an implant or a vaginal ring or an injectable that only has to be taken once a month or once every 5 years or once every 3 months makes our adherence and efficacy rate go up because we're taking away that human error of taking something once every day at a pretty close time frame. In 2006, this was I was a P3, emergency contraception, became available over the counter. In 2010s, we started seeing pharmacists being able to dispense birth control pills and patches without a doctor's prescription. And in 2023, we have the first over-the-counter oral contraceptive approved. This is the O pill, and it's just nodestrel by itself. So we've come a long way since using animal intestines as condoms, right? Looking at where pharmacists can prescribe contraception, there's a couple of different maps on the board or on the internet. And so you might find some different numbers based on current pending legislation in various states. But this seems to be a pretty good map. It says it's accurate as of September 24th, 2024. So all the states that are purple, dark purple, have pharmacists are available to prescribe birth control in some way, shape, or form. This one says that Maine is in progress, but when I look at Maine, everything that I can find on Maine says that it's passed through and it's available. So, but there are, I think, I can't remember. I think like 30 states where you can get birth control from a pharmacist. Now, the requirements in each state are different. Some of them require that you have special training. Some of them, it's only for people who are 18 years and old, sometimes older. Some of the restrictions are that it's pill and patch only or pill, patch, and ring. Some of them say that it's a collaborative practice agreement and a patient has to have seen their primary care provider within 1 to 3 years to continue the prescription. Others say that the pharmacists have to partner with the physician. So even though a pharmacist can prescribe birth control in all these states, the rules and regulations are different state to state. Yes, Nyla.
Hi, so I just had a quick question. If I know in the past, like countries that had low fertility rates, they would enact legislation like the Comstock Act that you talked about because they wanted to incentivize people to enhance the population of that country. Since we're already such a large country where we don't struggle with fertility rates like that. Can you kind of give us the why we had passed legislation and kind of current that's pushing for people to have kids in that same aggressive way?
I have a lot of thoughts and feelings, but I don't know that any of them are like within the scope of this lecture. I think that the Comstock Act came out about from a like it was a different world back then, very I don't know, conservative Puritan world type thing. And so it was seen as, promoting women to be promiscuous and, a control factor for women because in 1980 or in the 1800s, women, if they got divorced or if their husband died, they were not allowed to keep any of the things. They basically became homeless and assetless then. So I think that that has a lot to do with that. Women didn't get their right to vote until the early 1900s. So I think that has a lot to do with the Comstock Act itself and kind of the Puritan world that we were living in. That's around the same time as Prohibition. Um, and so I think it was just a way to control people. But I can't speak to, what's going on in our current climate. I mean, I can, but that's probably not appropriate for class.
And also, I think if I may add,
Yeah.
that the current system is set up so you need a broader base of young people to sustain a smaller, like pyramid of older people that are going to be consuming more resources from the government. So if you don't have like a broader productive base, like more people, more population, um, in younger productive years, and then you have all of this older people consuming all of this health, especially health resources, then it becomes unsustainable until the system changes. Like you need more younger people than older people for it to be sustainable.
Yeah, so that's a good point. Jose Avon, thank you for bringing that up. So baby boomers are the biggest generation. Baby boomers are people who are like my parents. So I'm 40, 41. And my parents are, my dad just turned 70 and my mom is like 60 something, 65, I think. And so those the baby boomer generation, that's the biggest generation. And so they are in their retirement years. And so it's taking a lot of more resources. Like it's Social Security is funded by the young people working. And so there's less young people working to support the huge population of baby boomers. So I think that's what Jose Avon was alluding to. And like the taxes that we pay for Medicare too come from the young people who are working. But I don't know that the government is trying to do these things from that perspective. I think that there are other motives besides outside of that. If we would just tax the rich their fair share, we wouldn't have any problems with Medicare and um, Social Security. But here we are. But yeah, that is an issue that's going on in the US right now and probably other countries. But I think that there's something a little bit more nefarious going on with the administration, but that's my political bias. So So since you work in Maryland and you're going to school in Maryland, let's talk about the Maryland contraceptive equity law. So as of January 1st, 2018, Maryland's contraceptive law, equity law, eliminates most copays for birth control. So that increases access because patients don't have to pay anything for their birth control. There's a list of pre-authorization requirements for IUDs and implants. There's coverage of vasectomies for men without co-payment, so equal opportunity here. A lot of times we see, that we put the birth control completely on the woman's shoulders, but here Maryland is like, hey, if a man wants a vasectomy, we're gonna let you have that without a copay. There's insurance coverage for OTC contraceptive medications like Plan B. So in Maryland, if you have insurance and you need Plan B, you can get the over-the-counter through your insurance. And it allows you to receive 6 months of birth control at a time, which is fantastic because most drugs we can only get 3 months at a time through our insurance. And so 6 months, again, increases access to care because you only have to go in twice a year to get this, and so you have it on hand and you don't forget to get your refills, increasing the use of this and making it more effective for patients. So this is a very patient-friendly law. So anybody who has insurance in Maryland, like any commercial insurance in Maryland has to offer these benefits because it is law. And so this is one of the benefits of living in a more blue, more Democrat state is that they put things like this in place. You'll also notice when we talk about fertility that Maryland has really good fertility coverage too. Not really good, but really good compared to other states that don't require fertility coverage. So, this is something to think about when you're thinking about settling down, where you want to live, what you want your life to look like. So effective January 1st, 2019, pharmacists can enroll with Medicaid, Maryland Medicaid as a prescriber of birth control. The complete training program, and then you have to do continuing education, but then you are able to prescribe birth control. I have been asking some of our former students how this actually works in the retail or in the community setting, and they say that it doesn't really work all that great because the big companies have not really set up for it. I don't know if any of that has changed since the last time I talked to some of our graduates, because I don't know if anybody works in a community pharmacy that can talk about the birth control, the pharmacist doing birth control. Oh, I know what's going on here. There's a timer on this slide for some reason. But anybody who works in community pharmacy that can talk about whether their pharmacies are doing birth control.
I worked in Safeway during the summer. I worked in Safeway in Boston Street down by the harbor, and they were like the top in the region for Safeway for prescribing. So I know they do it, and they were pretty successful. At least that pharmacy was really successful in it. I don't know details about it, but I know it was like we had a lot of younger females coming receiving
Okay, thank you for
the
sharing.
prescription from the pharmacist. Yeah.
Yeah, so Safeway seems to be doing it. Okay. Somebody says that they work in community, but they think they just dispense. They don't think the pharmacist prescribes, but they're going to double check. Yeah, if you work in community, it'd be interesting for you all to check out and let me know what pharmacists are doing. Because like I said, the last time I heard it was like a very cumbersome process for these big chains, and they hadn't delved into it. Probably looking at a cost benefit, and it didn't make a profit for them because we're not in the business of helping people. We're in the business of making profits.
And I think it might be part of the approach of Safeway. Safeway does a lot of, for what I've heard, a lot of like low profit margin things that other chains are not that interested on doing. So it might be part of it.
Yeah, I could see that because I would imagine that Safeway is a convenience. They have a pharmacy for a convenience for their grocery shoppers, much how Target, when Target owned their own pharmacies, like their pharmacies were complete money pits. But it was a convenience factor because they knew that people who came in to get a prescription would buy like 6 or 7 other items on average in the store. Where like CVS and Walgreens, the pharmacy is the moneymaker. The other stuff is they actually lose a lot of money on the front end of stuff. So I think Safeway has that same business model, that the pharmacy is a convenience factor for those shopping. If they're picking up a prescription, they're going to buy a little bit more there. than they might have if they weren't picking up a prescription. So. All right, so behavioral methods. Not to sound like you're, if you ever went to like Catholic school or Catholic youth group or whatever, not to sound like your church leader, but abstinence is the avoidance of genital contact. So you're not going to have sex, and it is 100% effective at not having STDs, not getting pregnant. So you can't argue with that. There's decreased performance pressure for one or both partners. Couples report increased emotional intimacy during times of voluntary abstinence. I'm just reporting what is in the data. Here, cons, it requires a commitment and self-control. So what if you say you're going to be abstinent and then all of a sudden you get into a situation where you don't have any self-control and you can't be abstinent? So then what happens then? Because you don't have anything readily available. You're not on contraception. You might not have condoms readily available. Long-term abstinence may be unsatisfying for one or both partners. Risk of STIs still may exist if you are having exchange of bodily fluids. So do think about that. I see somebody else went to Catholic school and their healthcare was a mess. Yes, I can relate. I only say that because I experienced that, and like abstinence was the only thing. All right, so fertility awareness and natural family planning. So this is contraception that relies on a couple predicting fertile periods in a woman's menstrual cycle and abstain from intercourse during those fertile periods. And so remember, cycle day 1 is the first day of the woman's menstrual cycle. We talked about this last week, and there's about 6 days of fertility per cycle because the sperm can live for 7 days. The egg is able to be fertilized for 24 to 48 hours. So you don't have sex 2 days prior to ovulation, or probably more around that. You are checking. Let me see what the. Oh yeah, so you're checking the woman is checking their basal body temperature. So there's temperature changes due to the influence of progesterone, and your body temperature rises after ovulation. So you're tracking that, seeing how many days your cycle is, seeing what day you ovulate on, and then you're avoiding sex during that ovulation time. There's also the Billings ovulation method where the woman checks their cervical mucus for changes throughout the cycle because there's increased mucus secretion, signaling that ovulation has occurred. Right. And then there's ovulation predictor kits that track that luteinizing hormone, that LH. Remember, I said LH surges when the woman is about to ovulate. And then there are menstrual cycle and fertility tracking apps, which used to be popular, but I don't know that they're all that popular in our current climate right now. Because remember, all your data on your phone, you do not own. It is sold. So do be mindful of that. But what do you think the biggest risk with these various methods are?
People can have conditions that cause them to have a surge in progesterone that isn't necessarily due to this, correct?
Potentially, there could be. I'm not sure off the top of my head about surges in progesterone, but I mean, it's possible, or if they get put on a medication or something, it's potential. It's possible, but I can't think of anything off the top of my head right now. I'd have to look into that further.
Having a natural fever could get the whole system out of whack.
Yeah, a natural fever could get the whole system out of whack.
I'll just say the human body is unpredictable, so it can be one size fit all. Never.
Yeah, so body can be unpredictable, and we've talked about that with patients who have amenorrhea, oligomenorrhea, PCOS. So maybe they don't have a standard cycle, so it gets hard to figure out when that ovulation is going to occur from month to month or cycle to cycle. Great. That's a really good insight, George. I don't know about you all, but I'm like really super stressed out about taking my, like, I'd have to take my body temperature every day. I'd have to document it. I'd have to pay attention or checking my cervical mucus. What if I think it's increased? You know, that's a very, the increase in cervical mucus is very subjective. It puts a lot of mental effort on the patient to do this. And you get a little bit lazy with this and you could get pregnant, right? Anybody else thinking about, like, because the basal body temperature, I believe, has to be taken before you even get out of bed in the morning. I mean, I guess if you're very committed to it, there are some people who are very committed to this and it worked great for them and good for them. I don't have the extra brain power for this.
I would say that if you're using this like to prevent, like to not get, to prevent like to get pregnant, you're still having risk of like STIs or things like that.
Yes. Yes. This doesn't account for STIs. All right. So the pros of this is that there are no effect on woman's hormonal status or their menstrual cycle. It gives you a better understanding of your reproductive physiology. So if the time comes where you're wanting to get pregnant, now you have all this data and you know exactly when to do it, right? It's inexpensive. Although a lot of the apps that I investigated, everything has a subscription fee these days. We used to have like CD subscriptions and magazine subscriptions, and everything became free for a while, and now we're going back to subscriptions for everything. So the apps are not, I don't think, I think the free versions don't have as many bells and whistles to be helpful. But it can be inexpensive if you're just getting a temperature or checking your mucus. The cons is, as Ernesto said, is that it doesn't protect against STIs. So when we're having sex, our only worry is not just contraception, but also potentially STIs. There's no cooperation from the male's side, as it all falls on the woman. It's difficult to use if the woman recently gave birth, because after you give birth, your cycle doesn't come back normally right away. If you're breastfeeding, you don't have a normal cycle. If you're perimenopausal and you're on your way to menopause, you're not having regular cycles, so that's not very effective. And then without sufficient training, it puts patients at risk of pregnancy. So there's coitus interruptus, which is the technical term for it. The lay term for it is pulling out. And so this is where the penis is withdrawn completely from the vagina before ejaculation occurs. The pros of this, that there are no side effects, there's no cost, it's always available. The cons is that there's no protection from STIs. It requires a high level of cooperation and self-control by the partner. So you are completely relying on somebody to do something to prevent pregnancy for you. The failure rate is 27%. Also, there is pre-ejaculate, which also contains sperm. So that is why the failure rate is so high at 27%, because that pre-ejaculate does contain sperms. We have lactational amenorrhea. So this is when a person is breastfeeding or chest feeding. Lactation is associated with decreased fertility. There's an old wives' tale that you can't get pregnant while you're breastfeeding. And so while it's harder to get pregnant while you're breastfeeding or chest feeding, it's not an absolute. And there are so many patients who get pregnant with their next kid while they're breastfeeding because they assume they can't get pregnant while they're breastfeeding. Just because you're not having a period doesn't mean you're not ovulating, all right? Some will say that this is no cost, but if you've ever breastfed a child or exclusively pumped for a child, my time is more valuable than no pay. Like the amount of time that you spend breastfeeding or chest feeding a child is equal to a full-time job. So I would say that there's a huge cost, but it's a cost on the woman. So, you know, society says that free labor doesn't cost anything. Complete breastfeeding is associated with a less than 2% chance of pregnancy within the first 6 months. So this is 6 feeds a day for 10 minutes or more. So at least 65 minutes a day of breastfeeding. All right, so that's a lot. And it's usually around that 6-month mark where people are still counting on breastfeeding to prevent pregnancy. And at that 6-month mark, the babies are experimenting with foods a little bit, table foods, and so they might not be drinking as much breast milk as they previously have. The cons of this is that we can't tell when the menstruation is going to return and when fertility is going to return. There's no rhyme or reason, predictability for it. The privacy and accessibility to infant, especially if you're working, might be difficult. When I started, so I had Thomas in June and I started at Notre Dame in September. And as soon as I started work and was away from him most of the day, my production, even though I was pumping, my production went way down. And he was 3 months old at that time. So so I might not have been able to, you know, pump enough or feed him enough to have this as reliable birth control. And I was lucky because since I was starting out at Notre Dame, I did not have a busy schedule. So I was just like, I am pumping, like there's nothing I have to be at. I'm training. I can imagine that for patients who their jobs are established and they're coming back to work, that's not the case. And I've worked with a lot of people in the medical world who get like 15 minutes to pump, and that's not enough time. You have to set up, you have to hook up, you have to pump, you have to relax to pump, you have to clean your stuff. 15 minutes is not enough time to pump. We have contraception or barrier methods. So there's the male condom, and it has a failure rate of about 18%. And this is for typical use. All right. This is not for correct use. This is for typical use. Most people don't use things correctly. It does prevent STIs. We have the female condom, and that's failure rate is 20%, again, for typical use. It also prevents against STIs, but maybe not as much as the male condom. Next, we have a vaginal sponge, and this is a polyurethane sponge that has spermicide in it. If a patient has not, NP means null polyposis. NP means no kid. So if you've never been pregnant and had a kid, it has a failure rate of 12%. If you've had a kid before, it has a failure rate of 20%. And this is likely because the opening is stretched out and there's more space for the sperm to go around and not go through the sponge and hit the spermicide. It does not prevent against STIs. And I have pictures in case you've not seen these things before. Okay. Next, we have spermicide. It has a failure rate of 22%, but if we combine that with a barrier contraception, that can increase or decrease the failure rate, increase the efficacy. It does not prevent against STIs. It's usually a gel that the woman inserts into the vagina to kill any of the sperm. We have a diaphragm with spermicide. This failure rate is 12%, and this is because the diaphragm is fitted to that woman's cervix. So if it's fitted, it's likely to stay in place and likely to not have any gaps. It does not prevent against STIs. You can have a cervical cap, which again is another way to put that barrier in your cervix there. Again, if you have not had a child, the failure rate is 14%, but it doubles, the failure rate doubles to almost 30% if you've had a child. And again, does not prevent against STIs.
I have a question.
Yeah.
Does like spermicide have any like adverse effects for the women? Is it like uncomfortable for the women, or is it is it safe to use?
So it's definitely safe to use. I think that if somebody has skin sensitivities or are more sensitive to chemicals, or like it's possible that it could be irritating. I have not really talked to anybody who uses it or has used it. It's not super popular, or it hasn't been super popular. I think it might be becoming more popular. But I would imagine that because it's a chemical, that there can be some, and it's going in, near a mucous membrane, that there can be some irritation for people who have sensitivities to different types of chemicals. All right, so we have non-hormonal intrauterine contraception, and the non-hormonal intrauterine is the copper IUD. So it is polyethylene, plastic T here, and it's wrapped with copper wire. It prevents the fertilization because it disrupts the transport of sperm to the follicle, to the mature egg. So it kind of messes up the sperm, so they can't get to that follicle that's ready to be fertilized. The copper ions increase prostaglandins and white blood cells in the uterine, and tubal fluids, which impair the sperm's ability to get to the egg to fertilize it. So it basically disorients the sperm. It's like, you can't go where you need to go, is what I think about. Right? It's good for 10 years. Can cause a lot of cramping for patients, and I think it can have a lot of breakthrough bleeding. But 10 years is a pretty good time, or good long time. Moving on to hormonal contraception, we have oral contraception. So some of the pros of the oral contraception is you can get progestin only. So progestin only would be what we would use after a patient has a baby and is breastfeeding or chest feeding. And because we can't use estrogen when the patient is breastfeeding or chest feeding. So progesterone only options are available for oral contraception. They have a lower side effect profile. The problem is that they have to be used within 2 hours. So you have to take it at the same time every day within 2 hours. If you hit that 2 hour and 1 minute, you have increased risk of pregnancy. They are very non-forgiving. And this is what the O pill is. So I would write, I think I have another slide, but this is the O pill, is progesterone only. So that over-the-counter birth control is a progestin only pill. All right. You can have a combined pill that has estrogen and progesterone in it. There's chewable options for this, but these pills are really small and very easy to swallow. So I think chewable is just a funsy thing. They have some formulations that help with acne. So depending on the type of progestin that's in there, you can have better acne control. You can use the combined ones to help manipulate your cycle. So if you skip the placebo pills, then you can skip your period. All right, and these are low cost. Some of the issues with these is that adherence with taking a pill every day can be tricky, especially if it's a progestin only and you have to take it within that 2 hour time frame. If it's a combined pill with estrogen is a little more forgiving, and you can typically miss about 1 day before having to use backup. They don't protect against STIs. Not an option for those with swallowing problems. I would say it had to be a really severe swallowing problem because, again, the tablets are really small. We have to think about drug interactions. Some of our CYP inducers and inhibitors can affect the efficacy of these, especially psych medications. And there's lots of strengths and lots of formulations, and it is just basically a guess, a check. You pick one, you like spin the contraceptive wheel, pick one, try it for 3 months. If it doesn't work, you spin the wheel again and pick something else. But it takes 3 months for the patient's body to get adjusted to it. So you don't want to switch before the 3 months. All right. So in our oral contraceptives, we have estrogen component in some of them, and estrogen can cause water retention. It can cause mood changes, headaches. It can cause nausea and vomiting. The weight gain, a lot of people will say they gain weight on birth control, but really, if anything, they retain a little bit of water, but they should not gain any weight on it. Birth control should be pretty weight neutral. And the data out there supports that it's pretty weight neutral. But patients really truly believe that they gain weight on it. Estrogen can cause spotting. It can cause breast tenderness. Venous thromboembolism is one of the side effects that we really worry about with estrogen, and is probably why an estrogen birth control will never be over the counter, is because of the risk of VTE or cardiovascular events. We have progesterone, which can be combined with estrogen, or we can use alone. Again, if we're using it alone, we can use it for patients who are breastfeeding or chest feeding. But progesterone can worsen acne. It can cause depression. It can cause hair loss. It can cause breakthrough bleeding. It can cause increased appetite. Again, weight gain plus or minus on this. So again, one of the things that we worry about with the estrogen component is VTEs and also cardiovascular events. So we should think about aches. So abdominal pain, which can lead us to think that a patient might have liver problems, gallbladder disease, or a blood clot. C, chest pain, shortness of breath or cough, which can lead us to think that the patient might have a PE, a pulmonary embolism, or a MI, myocardial infarction. H for headache, which could show us that the patient has uncontrolled hypertension, having a stroke or a migraine. E, eye problem, so double vision or blurry vision could indicate high blood pressure, uncontrolled blood pressure, or stroke. And S, severe leg pain, could indicate a DVT, a deep vein thrombosis. This is a slide I added late last night, so make sure you take a picture of it or a screenshot of it. So thinking about patients that have risk factors for complications, especially due to the estrogen component here. All right, and this is why we have pharmacists kind of gatekeeping and prescribing, and we don't make those combined oral contraceptives over the counter, is because of the estrogen. If the patient is greater than 35 years old, they're at increased risk of VTE or cardiovascular event, but that by itself is not an exclusion to estrogen. If they have any of these other things and they're greater than 35 years old, we should not be using birth control with estrogen. So if they have high blood pressure, especially if it's uncontrolled, we're going to want to use a progesterone or a non-hormonal method. If they're a smoker increases your risk of VTE because it causes damage to the blood vessels. It increases your risk of cardiovascular events. Again, going to want to avoid this. If their BMI is greater than 30, patients with BMI over 30 have increased risk of VTE. If they have a migraine with aura, so migraine is fine, but migraine with aura, these patients are at increased risk of stroke. So we would not want to use a contraception with estrogen in it because they're already at increased risk of stroke. Adding the estrogen to them could increase their risk of stroke. Any kind of inherited thrombophilia would be a contraindication to a birth control with estrogen. Personal or family history of cardiovascular events or VTE would be a contraindication to using estrogen. So again, it would be 35 plus one of these other things, or some of these other things by themselves or some of these other things combined. If the patient is high risk, we're going to use a progestin only method or a non-hormonal method. So again, we have this O pill that came out over the counter in 2023. It's O pill. It's a progestin only pill of Norgestel. It costs about $20 for 28 days or 1 month or 1 cycle, and $49.99 for 84 days or about 3 months, 3 cycles. So because it's progesterone only, what side effects do you think that the patient would have?
Acne,
Acne, great.
risk of depression,
Potentially depression, mood changes.
weight gain or loss.
Could be, so the plus or minus is for weight gain, could happen, could not happen, not weight loss. Sorry for the confusion on that. The weight gain plus or minus means like, yeah, maybe the patient could gain weight, but maybe not. The data is pretty clear that they don't cause weight gain. I see breast tenderness in the chat. That is actually would be something that the estrogen would do, not the progesterone component. Potentially mood changes, great. If a patient came to you and said, I'm breastfeeding and I'm really nervous about getting pregnant again, can I take this O pill while breastfeeding? What is your answer?
No.
No, why? Any other decisions, thoughts on whether you can use this for breastfeeding or not?
I think the estrogen component is the one that you cannot use. I think
Yeah.
it's safe that you can use the progestin component if you're breastfeeding.
Yep. So this is progestin only. There's no estrogen. Estrogen is what we can't use while we're breastfeeding. So this would be safe for somebody to use who's breastfeeding or chest feeding.
Dr. Hall, what about the problem of breakthrough bleeding?
So we would counsel the patient on that, and we would ask them to try it for 3 months. And if they're still having breakthrough bleeding at 3 months, then we would have to, and it was bothering them, we'd have to talk about using something else. Breakthrough bleeding can also happen when the patient is not being adherent and taking it every day at the same time. So we also could counsel on that. So we'd have to do a little bit more counseling, investigating, shared decision making with the patient on whether that was something that would be bothersome to them. All right. So the transdermal patch, its name is Xulane right now. The patch is changed weekly, so there's no daily commitment. It increases compliance or adherence because you're only putting the patch on once a week. You can wear it in the shower or the water, and it can be discreet depending on your skin tone. So if you're, glow in the dark white like me and this person in the picture here, probably discreet, but if you are a person of color, it becomes not discreet because it doesn't come in different tones. So you can see it. Application site, you can have a reaction because there is a stickiness to it to get it to stick and to get it to stick through the shower and swimming and things like that. So it can bother people who have eczema or sensitive skin. It can cause nausea, and it's not, it has reduced efficacy in women who are patients who weigh greater than 180 pounds, so we can't use it. Y'all, the patch scares me. I know it's been reformulated since I was a student, but on my first API rotation, we had 2 patients who were in their 20s and 30s in the hospital with pulmonary embolisms. and the only risk factor they had was the birth control patch. So that has completely freaked me out about the patch because the absorption is so much better. It was a higher dose back then, but that's why I'm so good at anticoagulation, because right off the bat, talk to them about their PEs and their heparin drip and switching them to warfarin and things like that. So the VTE risk with estrogen is very, very real. All right. I want you to really remember that estrogen, when we say it could cause a VTE, like a PE or a DVT, that's a real risk. And that should be scary to us. All right, let's take a 5-minute break. I have 2:57, so what that puts us at like 3:02.
Mm.
Couldn't believe my daughter upgraded her bed.
All right, we will resume. Okay, so next we're going to talk about the vaginal ring. The vaginal ring is estrogen only, just like the patch is estrogen only. The patch or the ring is inserted for 3 weeks at a time. It can release hormones for up to 5 weeks. So if you want to skip the period, you can keep it in longer. But if you want to have a period, you put it in for 3 weeks and then take it out and you have a period. It delivers the hormone locally, so to the cervix area. So there's less systemic side effects. It can induce amenorrhea. What's amenorrhea?
Menstruation.
I'm sorry, what was that, Kingsley?
I said, could that be lack of menstruation?
Yeah, lack of menstruation. So A means without, menorrhea without menstruation. So it could make a patient not have any periods at all. It's discreet because it's inserted in the vagina up near the cervix, and that can help with compliance or adherence. There is a yearly option, a Novera. I've not seen that used. Some of the cons are that women must insert it themselves, and it may not be preferred for all women. There's no STI protection with this. If the woman is predisposed to vaginal irritation, this can increase the risk of vaginal irritation. Also, think about women who have maybe a yeast infection or maybe BV. And so if that is going on, you probably don't want to use that until the infection has cleared. The ring may come out with tampon use, sexual intercourse, and strenuous bowel movements. It must be stored in the fridge at the pharmacy, and it's good outside the fridge for 4 months. So this falling out is a bigger issue than one would think. I worked with a doctor in South Carolina who got pregnant with her 3rd kid because her husband found a ponytail holder on the floor in the bedroom. It wasn't a ponytail holder. It was her Nuva ring. She didn't realize she had lost it. Her husband, when he found it on the floor, didn't realize that it was a Nuva ring and not a ponytail holder. And so she got pregnant with her 3rd kid. So, that is, something to be aware of. I remember there was a question once I had, mine fell in the toilet. Can I reinsert it? The answer is yes. If it falls in the toilet, you can rinse it off and put it back in. So everybody be leery of any ponytails they find on the bedroom floor or the bathroom floor.
So the rinsing would not take away the hormone, huh?
Nope, the rinsing would not do nothing to the hormone.
Oh, well, okay, good to know.
Yeah. All right, so next we have depot medroxyprogesterone. This is injection, can go in the arm or the butt. Pros is that it's injectable. It's discreet because nobody knows you're getting it unless they know that you have an appointment and you're going to the appointment. You take it every 3 months. It can be administered in the doctor's office or it can be self-administered, although I think most places it used to be administered mostly in the doctor's office. I don't know if that's changed in recent years. It's a low cost option and it doesn't have any estrogen in it. So this would be good for somebody who maybe has a history of cardiovascular events or risk factors for VTE. Reduce depression rates with it. It's safe in postpartum and breastfeeding patients because it doesn't have estrogen in it. But some of the things we need to think about is that it can lower bone mineral density. So we can only use it for 3 to 5 years. It can cause menstrual irregularities and amenorrhea. There's a delay to return to fertility for up to 1 year. So you can stop it and you can still have trouble getting pregnant for up to 1 year because of the medication. So where some of the other things that if we stop them, our return to fertility is pretty quick. This one, it is not. This one has significant weight gain. This one truly does have weight gain, and we do need to monitor the patients for that. We're talking about 10 pounds over 6 months, and that really changes a person's or really can change a person's perspective on themselves and how their clothes fit. And so this is a big issue with this particular drug. It doesn't prevent STIs, and oftentimes you have to go to the MD, the provider office to get it. It was very popular for military people when I worked in Florida at the military base. So maybe that's why I don't really know if it's popular outside of doctors' offices or not.
So also in this case, after 3 years, when they have to figure out what then happens to the patient.
After 3 years, so you can only use it 3 to 5 years. You would want to be watching their bone mineral density closely. If they're healthy and active and getting enough calcium, might be okay, but they might need I'm not sure, they might need a DEXA scan if they want to continue it, or the doctors might or providers might just not continue it. But if you're going to check their bone mineral density, you would get a DEXA scan to check to see where they're at. But it's something that we would consider. We have a subdermal implant that goes underneath the skin. It's kind of subcutaneous in the arm. It gives you a small daily dose of progesterone, and improved adherence with 3 years of coverage. So it goes in and it lasts for 3 years. If you remove it, your return to fertility is immediate. So this is for somebody who, is like, well, I don't know when I want to get pregnant, but when or maybe older patients who are trying to delay and but want to be able to get pregnant right away when they stop their birth control. This would be a good option. It can be used postpartum and patients who are breastfeeding or chest feeding, and it has a 99% efficacy rate. Because it goes underneath your skin and it's a device that goes underneath your skin, you obviously have to have it inserted at a provider's office. The number one reason patients have this taken out is the irregular bleeding. They cannot tolerate the breakthrough bleeding and irregular bleeding. So I don't know if people didn't do a good job counseling on it, but you should expect some irregular bleeding when you first get it in, but a lot of patients get it removed sooner because of the irregular bleeding. There can be insertion site pain. It's an invasive procedure and there's a high upfront cost for it. Right, so next we have the IUD. So this is not copper because there's not copper wires here, but it's the same concept, a little plastic tee that goes into the uterus. And these IUDs can have hormones in them and release hormones. So this would be like your Mirena or your Skyla or Kylena. They're 99% effective. After removal, the patient has an immediate return to fertility. The duration of efficacy, you can leave them in from 3 to 10 years, depending on which IUD you get. When they first came out, you could only use them if you've ever had a child before. Now they will give them to you even if you haven't had a baby before. There's no issues with adherence, although there are some reports of them falling out if you get them put in like immediately after you give childbirth. Sometimes you can get them put in immediately after childbirth, but there's a higher risk of them falling out. Oftentimes they'll make you wait 6 weeks to have it put in after childbirth to reduce the risk of it falling out. I'm a little bit skeptical of the stories of them falling out. I don't know if I've not seen any true data, just anecdotal stories. So, think of that what you will. Um, it's also approved to treat menorrhagia, and it can often induce amenorrhea. And there's low exposure to hormones because it's going right in, it's like a topical hormone right into the uterus. There's no STI protection with it, and it must be inserted and removed at a doctor's office. If it's a copper IUD, it can have long periods, so that is not ideal with the copper. There is pain at insertion for patients, especially if you've not had a child prior to getting one. My first IUD I got before I had Thomas, and I almost passed out on the table. I had to go back in under some benzos and some painkillers to go back in and have them try and get it in. So it is not benign to just get it inserted. The one I got after Thomas was easy peasy. Rarely, but the IUD can move, so you're supposed to check the string periodically. There can be infection with this, but that's also very rare, and it is quite expensive upfront. So what happens if we've tried some of these things and they fail? We need emergency contraception for whatever reason. So emergency contraception is postcoital, so after sex form of contraception to prevent unintended pregnancy. We can use things like combined hormonal, so you can take a double dose of birth control. You can use progestin only, which is your plan B. You can use this allopristol Ella agent, which I've never seen before, but it's available. Or you can have a copper IUD inserted. So when can emergency contraception be used? If there's been no contraception used, so you didn't use a condom, you're not on oral contraceptive pills, and you have something happen that you need emergency contraception, you can use it. A lot of times we'll see emergency contraception used after sexual assault when the patient was not protected by an effective contraceptive method. Or if we're worried that our contraceptive method failed. So we're worried because the condom broke, or there was spillage, or incorrect use, or we missed 2 of our pills, or we missed we're on the O pill and we took it 4 hours late. Any kind of thing that would make us think that our contraception failed, we would want to use emergency contraception. So the mechanism of contraception, emergency contraception, we can use our combined oral contraceptive pills. So these would be estrogen and some kind of progesterone. We want to get 100 micrograms of ethinyl estradiol and 0.5 milligrams of levogestrel. And then we want to repeat that 12 hours later. So by doing this, we're going to prevent the ovulation if it's prior to the LH surge. But this also increases the cervical mucus, which makes it harder for the sperm to pass through the cervix. So if if they have their contraception pills on hand, they can just take double dose and repeat it 12 hours later. Thing is this is probably going to make them pretty sick. They're probably going to be pretty nauseated by this. So you're going to have to counsel them that if they throw it up, that they're going to have to take another dose. Excuse me. And we want to do this as soon as possible because it's more effective the sooner we take it. We have emergency contraception pills. So we have Plan B, which is the levonorgestrel. And it prevents ovulation. Again, if it's taken prior to that LH surge of the menstrual cycle, it increases cervical mucus again. So it works very similarly to the combined oral contraceptives. And then you have allopristol or Ella, which is an anti-progesterone. And so that's going to also suppress or delay the ovulation and increase the endometrial thickness. You notice that nothing here says that it interferes with pregnancy. Everything that it's doing is interfering with the sperm fertilizing the egg. This does not, if a patient is pregnant, if that egg is fertilized, it's not going to, and if that fertilized egg has implanted, nothing is going to happen. The emergency contraception is not going to do anything if that fertilized egg is implanted. So what the emergency contracepting is trying to do is trying to prevent the egg from being fertilized. And if it's not able to catch the egg from being fertilized, it's trying to prevent it from implanting in the uterus. But it doesn't do anything once the patient is pregnant. That's why it's really important to use it as soon as possible. We're talking 120 hours to 5 days. We now have Plan B one step. It's over the counter and there's no age restriction and there's no ID required for purchase, and we can use it up to 72 hours after unprotected sex. The Elapristol or Ella requires a prescription and you can use it up to 120 hours after unprotected sex. The copper IUD acts as a spermicide, and because the copper ions are directly toxic to sperm, and you can insert this up to 120 hours after unprotected intercourse. You probably would not want to use this one unless you want to maintain it for contraception, because that's a procedure, and like you wouldn't want to put it in and then take it out. That would be a lot of trauma. Side effects associated with the pills are nausea, vomiting, fatigue, dizziness, breast tenderness, especially if there's estrogen, and menstrual spotting, but usually pretty tolerable. So our contraception plans didn't work. Our emergency contraception plans didn't work. We find ourselves pregnant. We could, with an unplanned pregnancy, we could need a medical abortion, but we could need a medical abortion for a lot of other reasons besides a unplanned pregnancy. So please keep this in mind that medical abortion is a medical term. It is not a morality thing, or a judgmental thing. A medical abortion is a medical term that we put in our charts, regardless of what the reason was for the medical abortion. So, thinking about pregnancies, there are unintended pregnancies are about 50% of the 208 million pregnancies per year, and about 40 to 60% of those unintended pregnancies end in abortion. But if we're looking overall at all pregnancies, 30% of all pregnancies end in abortion. So outside of unintended pregnancy, for ending in abortion, we can have abortion because the pregnant patient has severe preeclampsia, early eclampsia. They can have premature rupture of the membranes. The pregnancy can fail before 20 weeks of gestation. So that would require abortion. If the fetus dies after 20 weeks, that can require an abortion. Again, this is a medical procedure. If there's a fetal anomaly, if there's medical conditions, so if there's a psychiatric condition where it's not safe for the patient to be pregnant, if there's malignancy, is a cardiovascular disorder, renal disorder, endocrine disorder, a whole bunch of things. If the fertilized egg implants in the fallopian tubes, that's an ectopic pregnancy, and that requires an abortion because that will kill the pregnant patient. All right, 60% of abortions occur in the US before week 10. Medical abortions account for about 40% of all abortions in the US. And this is 45% of abortions worldwide are reported to be unsafe. Abortions are the leading cause of maternal morbidity and mortality, despite being the most preventable cause of death for patients who are pregnant. Jose Avan, did you have a question?
Oh, I was gonna ask. I was trying to make sense of the 208 million pregnancies. That must be worldwide, right? Because like, there's no way that the entire 2/3 of the U.S. population a year.
I'd have to go back and check, but I'm pretty sure it's worldwide. So again, a medical abortion, induced abortion is not just for patients who don't want to be pregnant and don't want to have the baby. This is a lot of reasons that a pregnant patient could need an abortion to save their life. And it's really struck me that 45% of all abortions worldwide are unsafe, and abortions become unsafe when we have rules and regulations, strict rules and regulations to prevent abortions from happening. And that leads to pregnant people dying or people who have just delivered dying. I'm very passionate about this issue. Just a full disclosure, I had, and we'll talk about that more in a couple weeks, but I had an ectopic pregnancy that required an abortion. And that was very traumatic for me to have to go through that. And I was living in Florida at the time. So to know that if that were to happen to me today in Florida, that I could potentially not get that life-saving procedure when there was no chance of that fertilized egg surviving is really disturbing, is really upsetting to me. So if I seem a little bit passionate and over the top about this, it is because this could have the legislation that is happening since the Dobbs decision could have really impacted me in a negative way. And I might not be teaching you here today, which some of you would be very happy about, but yeah. So when you think about it from that standpoint and you have a close experience with it, it really becomes, a passion project. So the WHO recommends options for healthcare providers for medical abortion services. So the WHO recommends that medical abortion be available to patients for less than 12 weeks gestation. So that's patients who are in the first trimester. And they will say that it's safe for patients using self-management strategies, using telemedicine. So if we can use telemedicine, we increase the access to the medication, we increase the access for these patients. They recommend that it be available through community health workers. So these are people that we train in rural areas who can give the medicine when needed. They recommend that it be available through pharmacy workers and pharmacists. They recommend that it be available through traditional complementary medical professionals, nurses, midwives. All right. And so the WHO really recommends that this be readily available to patients through various medical professionals. For patients who are 12 weeks or more pregnant of gestation, we want them to see a non-generalist or a special medical practitioner, because these patients might also require surgery. The medicine might not work, the medications might not work, and they might require a surgical intervention. But before 12 weeks, it is very unlikely that these patients would need a surgical intervention, which is why the WHO recommends that it be available from all these providers. After 12 weeks, there's the risk of the medications not working and the patient needing surgery. So which drugs do we use for that first trimester medical abortion? We use mifepristone, 200 milligrams, and then 24 to 48 hours later, we use misoprostol. Remember we learned about misoprostol yesterday and GI? Yeah. What is it? What do we learn about it for GI, and what is it used for?
Reducing bleeding chances, I believe.
Yeah, so it prevents the risk of an NSAID-induced ulcer. It's cytoprotective in the stomach lining. And we said one of the things that we can't use it in patients who are pregnant. And this is why we can't use it in patients who are pregnant or trying to get pregnant, because it by itself is an abortifacient, and it combined with mifepristone is an abortifacient. So this is what we're talking about when we're talking about a medical abortion, is the mifepristone and the misoprostol together. You can use mifepristone by itself, and it's about 97% effective up to 63 days of gestation. So mifepristone is available through a REMS program, and that's because of the increased risk of infection or sepsis. So if the drug does not fully clear the products of conception, and some of that is left behind, the patient is at increased risk of infection and sepsis, and then also prolonged heavy bleeding, which can lead to anemia and issues with that. So there's a REMS program, which requires that the patient be have full informed consent before they get the medication. The FDA revised the mifepristone REMS during COVID to prevent. You used to have to get it from a special pharmacy. Now you can get it from all retail pharmacies who obtain the certification. You can get it through the mail. And again, this is to increase access to care because during COVID, it was really hard to get into these specialty pharmacies and clinics to get it. And the data, they evaluated the data and said that it's relatively safe if the patient has proper counseling. So side effects greater than 15%, they're going to feel sick. They're going to feel really sick. They're going to be nauseated. They're going to have weakness. They're going to have fever, chills, vomiting, headache, diarrhea, and dizziness. So we do want to be mindful that this is not benign, that these patients are going to feel pretty sick after this. And so thinking about how we're going to manage their side effects, we're thinking about pain. We're going to use NSAIDs preferably. If we can't use NSAIDs, then we're going to want to use acetaminophen. We're going to make sure that they have antiemetics on board. So after tomorrow's GI class, you'll know which antiemetics would be appropriate for these patients. And then supportive care, rest, is probably the number one thing. Staying hydrated, right? So one of the things we talked about, I think, on our first day is that there are some people attacking mifepristone, that it's not very safe. And so while there are a lot of side effects and people don't feel overall very well, let's look at those serious side effects. So only 0.1% of patients who take mifepristone for a medical abortion have a hemorrhage, which means they're bleeding uncontrollably. That's very low. Patients who have a medical abortion, about 8% of them require or have retained products of conception, so they have an incomplete abortion, but less than 5% of those patients require surgery. There's concerns that the mifepristone doesn't work and they're going to have an ongoing pregnancy. That risk is 0.2 to 0.7 of early medication abortions end up in an ongoing pregnancy. And it's more common if we use an oral or lower dose of misoprostol. So the misoprostol we want to be using vaginally to help prevent that. Upper genital tract infection is less than 1% of all induced abortions, and it's rare in patients having a medical abortion. So these, these dangerous side effects, and this medicine is so dangerous. The data doesn't really support that, in my opinion. So,
Dr. Holt,
yes.
I didn't understand the second section, ongoing pregnancy complication. What is this about?
So the pregnancy was not terminated. The pregnancy continued despite taking the mifepristone and misoprostol.
Would that be like a normal baby, or does that risk baby being?
I think that's hard to say from, I'd have to look into it more, but I think it's hard to say because there's a lot of things that can happen between the first trimester and the delivery of the baby if they choose not to do another dose or something like that. I'd have to dig into the data a little bit more. So we had the Dobbs decision that overturned Roe versus Wade. Roe versus Wade was the Supreme Court case that gave women all across the United States the right to abortion. Dobbs overturned that and said, that's not a U.S. right anymore. That's a state right. All the states have to decide. So that's why you're seeing all these state legislations coming up with abortion rulings or whatever. So the same people, or not the same, I don't know if it's the exact same people, but the same type of people that brought Dobbs to the Supreme Court brought this AHM versus the FDA. And this was in 2023. They decided they made the decision in June of 2024. So it's no longer ongoing, but this AHM, which is a very conservative Christian group that supports Christian providers and finds people to fit their narrative of what they want the rest of the U.S. to do, essentially. said that the FDA did not conduct proper trials to approve mifepristone. Mifepristone is very dangerous. It should be removed. The FDA should reverse its approval. Luckily for us, for right now, on June 13 of 2024, there was a unanimous decision. So that means all the Supreme Court justice said, this AHM, you don't have any standing. This mifepristone, in lack of standing, means that the AHM, the people who are suing, are not harmed by mifepristone and the FDA's regulation of it. So if they are not harmed by mifepristone and the FDA's regulation, they cannot bring this case to the court. And so basically the court dismissed it, saying you have no standing to sue on this. Because there was no injury to the plaintiffs. There was no injury to AHM or the doctors or providers that the AHM was gathering to bring this case. And there was no direct harm for them, because there's conscious clause. If you don't want to do something, you can say, like, I'm not going to do this, and somebody else, there has to be a contingent plan for somebody else to step in, right? So, so everything remained the same. And that was a big sigh of relief to me until I started reviewing this again for the class. And now, you know, they said that AHM didn't have this, but that that the other states and other people could continue to bring their cases to the courts. And so now we're seeing right currently 3 Republican-led states, Idaho, Missouri, and Kansas, have continued the efforts to restrict mifepristone, saying that their Medicaid programs may bear the cost for treating complications of the drug. And this judge was hand-selected by Trump, and almost all the reproductive cases go up through him. They bring, I think he's in Texas, and they find somebody in Texas to bring the case up to go through his court, because they know that it's going to potentially get through. So it'll be interesting to see what happens. And I think I'm trying to keep up with everything, but I think there was just a new maybe executive order or something. I seem to remember, I don't quote me on this, about Medicaid not being able to pay for abortions right now. So while this affects a drug that obviously has a lot of, you know, there's a lot of medical around it, there's a lot of morality and what people believe and feel from their religious standpoints, and things like that. Like, I really want you to think about how might these types of court cases and decisions not just impact mifepristone and drugs that, like, people have moral stance against, but what about other medications, right? And how can you know, cases like this, court cases like this, impact patient care? You know, I don't know very many judges who have a medical degree and are able to sift through the information. And last year in Women's Health, I had a group dig through the AHM briefing, what they filed with the court, and the resources that those lawyers were using to support their point was just, they obviously didn't take CRD or EBM, like cherry picking their data to support their point. All right. And so just think about that, because this is a slippery slope, right? It starts right now with this drug that has moral implications. But what happens when it gets to other drugs that don't have those same moral implications? Do we really want our judicial system determining our right to access medications? All right. What questions do you have for me?
Yeah, can you go over the procedure for the checkpoint one more time, please?
Yep, absolutely. All right, so you should be able to go on Exemplify now, and it should be posted. So you should see checkpoint 1 for Women's Health, able for you to download it. And then I'm gonna put I'll put the password in the chat, but I'll also post it on Canvas, but you'll just type in the password and then you'll take the quiz. There's 25 multiple choice questions. Because it is open book and open note, they are probably a little bit trickier than the PT questions that I create. And there are some that require, like we haven't talked through all the ways to apply this information. So it might be they might be, even though there's only 25 questions, they might be a little bit trickier to get through. So make sure you plan enough time. I am not 100% sure if you can like start it and go back to it once you start it in Exemplify. So I would make sure I have at least an hour to do the quiz. 25 questions, that's what, 2.5 minutes, so that you can get through it without shutting it down there. The quiz is open until next Monday, the 3rd. So it is due on February 3rd by 11:59 p.m. Eastern time, your time. After everybody has taken the quiz, I will send a message out through ExamSoft that will allow you to review your results, and we'll give you feedback. If you have any issues, let me know, but please don't wait until like 5 minutes before you take the quiz to download it and take it, because it is 25 multiple choice questions. I said they're open book, open note. They're a little bit more tricky, I think. And I will not accept late work. I think that's in the syllabus that we don't accept late work in this class. You have a week to do it. Put it on your calendar, put a reminder in your phone, make sure it gets done. Next week, Dr. Park is coming to talk about pregnancy. She'll be here for the next 2 weeks, so it'll be in person. So you need to be in person for her lectures, and then the following week, I will be on campus in person for that lecture. So the next 3 weeks will be in-person lectures, which I think is noted in the syllabus. There's no time limit for the quiz. You can take as long as you need for it. So I will see you tomorrow in PT, but I will not see you in this class until February 18th, and we will be in person together. So, but if you need anything, please reach out.
Thank you, Dr. Hall.
Yeah, thank you all.
Thank you, Dr. Hall.
Thank you, Dr. Hall.